To get us started, I'd like to introduce Karam Radwan. Dr. Radwan is the Division Chief of Child and Adolescent Psychiatry Program at the University of Chicago. He's board certified in adult psychiatry, child and adolescent psychiatry, and hospice and palliative care medicine. Dr. Radwan has been the Director of Training for the Child and Adolescent Psychiatry Program, Fellowship Program for the last 15 years. He's a Distinguished Fellow of the American Academy of Child and Adolescent Psychiatry. His professional work focuses on promoting family assessment and interventions, studying the effects of play on cognitive flexibility, and promoting evidence-based treatment in child and adolescent psychiatry. Come on up, Dr. Radwan.
Good morning, everyone. I'd like to thank Dr. Wong, and the Center for inviting me to join you today. I'm interested in promoting mental health. My other hat that I'm often involved in is working on a global level. I'm interested in global mental health, promoting mental health in the developing world, and also learning from some of that work, how we can bring back tools and interventions and low resource places that we can probably use here in our backyard. I'm going to try to kind of go over some of the history and the state of mental health, and then kind of tie it to some of the current events that Dr. Bowman reviewed. I don't have any financial conflicts at this time. So these are the objectives. We're going to talk a little bit about adolescence as an important time of development, as a period of vulnerability, but also a period of opportunity for intervention. We'll review the current state of mental health in adolescence, and then focus a little bit on suicide, substance use, and then later talk about kind of a vision for a different system than the one we have, and maybe talk about potential advocacy, especially for policy. I know many of you involved in policy. But to start, I want to talk a little bit about adolescence. Adolescence is a great time. It's a magical time. You're all children. It's a very challenging time for parents and for school, and many people are involved in the care of adolescents. In the world, adolescent now is about quarter the population. We never had more adolescents than the current time. It's about 13% of our own population. And if you look at theory of development, if you take a look at, I think you probably heard of Piaget and cognitive development. Adolescents actually are capable of tackling issues similar to adults in terms of abstract thinking. If you present certain problems, they are capable of presenting similar answers. But that assuming they're not under an emotional event or activated emotion. And that's the true problem in adolescence. So it's how to manage their emotion. Emotion gets in their way. Emotion gets their impulsivity to be on a different level. But from an abstract point of view, they are in the formal operation cognitively. Now, from what Erickson described as important hurdle in life, and adolescence is a time of identity formation. So that's where their identity formed. That's where they identify with social causes, with issues relevant to them. And often that can really motivate them and kind of stay with them for a pretty long time. But how adolescence starts? It starts in the brain. Puberty starts in the brain around depend on that. Now we know we have more evidence that puberty is happening earlier than before, but start in a place called the hypothalamus, where they release GnRH hormone that affect the anterior part of the pituitary gland, and that's where FSH and LH get released, and that in return affects the release of testosterone and estrogen. But the interesting part, the testosterone and estrogen affect the brain in a really unique way. They affect area of motivation, like the nucleus accumbens. It affects amygdala, where it's an important part of processing emotion. And it's also affect how the social component of the brain is changing. And these changes are so unique to adolescents and make this time, again, a magical time in a way, but really challenging for parents. I know many people laugh when I said that. But it's a time that happened only once in the lifetime. Now, in the past, adolescents always been described as they're extremely impulsive. They have all the parts of their brain ready as an adult, but they don't have the brakes. They have the engine, they have the gas, they have everything, but they lack the good brakes. And if you see what happened in terms of maturation of the brain, it starts from almost the back, where gray matter mature. And the last part that really mature is the frontal part, which is the part that is responsible for executive functions, planning, organizing, suppressing impulses, looking at long-term gain. And now we have incredible data that's filed for 20 years looking at adolescent and how that part happened. But what I wanted to share with you that this maturation part ends at age 25, 26, does not end at age of 18. So from a neuroscience view, adolescent end around 25, not 18. So there's not much difference between 18 and 19, except we now look at adolescent as, they're independent, they have to survive on their own, they can vote, they're legally responsible, they can try in adult court. I mean, we put them through all these things, but from a neuroscience view, not a huge difference. And if you have ADHD, that maturation happened at age 28 or 29. And so it's even 3-4 years behind. Now, what makes adolescent really hard is this emotional sensitivity. They are driven by emotion. That nucleus accumbens that I show you, it's on fire when there's peers, when they are extremely interested in making new connections. There's this phenomena that's been described in adolescent. When you see them with their friend, they're in like synchrony. They're acting the same way, they're laughing the same way. They're really driven by that social component. And that can be great, but also can be destructive if they're in the wrong place, the wrong time, the wrong peers. There's so many things that can go wrong. But they are driven to learn about social relationship. They are also interested in self-discovery, trying to fit in the social work, how they fit in that social hierarchy. And it's the time of mentalization when they start learning how to take perspective of different people, trying to understand how the world can be different outside of their own view. Now, emotional regulation, I'll say, it is the task that they need to master to move on. And it's not an easy task. It's not easy for a lot of different reasons. First, they do experience more frequent and intense emotion than children or adults. Their experience of emotion is so intense. And if they happen to have a trauma, they also experience that at a very intense level that it's going to be different than adult. Now, this emotional regulation requires them to learn a new skill that they have not learned when they were children. Skills of regulating emotion, trying to understand how not to make a decision when they're in that state. And that's not an easy thing. Like I said, if you remove them from that part, they're capable of having an abstract thinking similar to an adult. You add the emotional part, they're completely off. So it's kind of back and forth. But we're gonna tie this into a little bit of the state of mental health right now in that population. And I think Dr. Borman kind of reviewed some of that data already. But I can tell you our kids are not doing okay. Not doing okay on many levels. They experiencing more psychiatric disorder. That's true not only in the US, but across the globe. We know that, and I'll show you more data on the trend of where that's going, because that's, I think, interesting for a policymaker to kind of see that. But half of the adolescents now have what we call a psychiatric problem. 20% of them have a severe psychiatric problem, not just a psychiatric problem. And then anxiety is about a third of the adolescents have an anxiety disorder. This is not the normal anxiety that they should have to worry about exam and stay safe. This is an anxiety was actually disabling them, stopping them from going to school, stopping them from engaging with others. Depression, as the WHO label as one of the most disabling illnesses. If you get that in adolescent, you're more likely to have a recurrent chronic illness in your adult. So that's a very bad illness to have at that age. Now, there are many components that we're going to review, but most of this data is coming from the CDC. They do a survey every 2 years on an odd year. And this is a survey that they look, it's called Youth Risk Behavior Surveillance System. And this is where they ask, trying to see what is the trend of problems that get people sick and put them out of harm's way. And so this survey has been going on for many, many years. If you look at the last one that we don't have the data for the 23 yet, we'll have it next year. But if you look at the last one, 57% have persistent feeling of sadness. This is not the normal mood changes that we have. We all feel sad and for a day or two. This is a persistent lasting weeks, which is a component of how we diagnose depression. 57% of girls experience that, and 29% of boys experience that. If you're going to see the color here, if you see red, that means trending in the wrong direction. If you see yellow, this means kind of staying the same. If it's green, it's going in the right direction where we want to see it going. Now, if we try to look at ethnicity, and I'm going to show you several slides related to that, we can see that multi-racial and Hispanic had more of the persistent sadness. And if we look at competition for grade, we know that there's a big drop that happened a little bit before COVID hit, but continue and exacerbated by COVID. And if you look at performance, academic performance is going down. Now, why that's important? Because it's also tied to how some of these adolescent experience. If you are a low achiever, you're more likely to have depressed, persistent type of mood more than the high achiever. And that's so true for girls. You can see huge jump in that. Now, there's another problem that hardly people talk about, which is chronic absenteeism. That's defined by missing about 10% or more of school days. And this is from the Department of Education. This is what they call the hidden educational crisis. If you look at the number, 20% of students in high school are chronically absent. In Chicago, in CBS, about almost quarter of the students miss more than 10% of school days. Now that's more prevalent in minority group and in low-income students, and it also predicts school dropout. So it's also a bad indication. So it's a problem that we need to tackle. In the mental health, we see some of that, some we call school refusal. But there's other reason why kids are not going to school. It's not just because of school refusal. Some related to safety, some related to difficulty with transportation, some related to the parent not doing well themselves. So it's a big problem. If you look at Illinois, this is comparing 2018 data with 21-22. We went from 18% to 30%. Naturally, that's happening everywhere. I mean, places like Alaska and DC, half the students almost now are absent more than 10% of the school. Now, the perception of safety. So this is the percentage of kids who miss school because of safety. And you could look that Black and Hispanic topped on this. This is something that should be tackled by our policymaker. We need to figure out a way to change that because again, that's going to have a devastating effect. Now, it's hard to talk about adolescent and not talk about suicide. Earlier, I was talking to Dr. Borman about a pediatric resident still not required to do rotation in mental health. But if you look about the 3 leading causes of death in adolescent and young adult, there are accident, suicide, and homicide. They're not cancer, they're not heart attack, none of the things that we train our pediatrician to take care of day in and day out. I think that's going to change, hopefully soon enough. But suicide is a serious problem. It takes away the precious young adolescent and young adult. The rate has been going up. It almost doubled in the last decade. And I'll show you a trend also that I think is good to look at. Well, we also know, which is really alarming, that there's an increased rate for suicide in pre-adolescence, especially in Black boys, age 5 to 12. And that's been the case for the last 5 to 6 years, which we have not seen before. Before, we did not worry too much about suicide, pre-adolescent suicide, but that's also changing. In the 90s, we had a big jump, and then suicide went down till 2003, and from 2003 till now, suicide's been going up. Now, there's a lot of correlation of why that happened. In 2003, FDA released a black box warning for SSRI. Now, is that related? We don't know, but that's an important thing so we can look back. The black box warning basically alarmed pediatrician, primary care physician to almost think twice before using antidepressants. Because there's 2% increase above placebo in suicidal ideation. And we know that the use of antidepressant dropped for a while after that black box warning. But there are many issues that probably driving this. This is probably not the one driving this. Now, from the CDC data, if you look at what's happening, this is adolescent from a neuroscience view, but including young adult, age 10 to 24. So you can see that suicide is going up. We also have a sharp increase in homicide in the last few years. If we break it down to early adolescent and late adolescent, you can see that suicide in early adolescent is going really high, and late adolescent is still going up, but homicide is even topping up in many states. Now, if we ask people if they're seriously considering suicide, about a third of our adolescent girls consider it. And this is also going in the wrong direction. And this is a serious consideration, not a fleeting thought of, how does it feel if I'm dead? That's not what this question is about. Now, maybe Dr. Bora will talk about Illinois' data. But in Illinois, at least 2 years ago, suicide was the 3rd leading cause of death in adolescent young adults, almost losing 1 every 4 days. So it is a significant increase. If you experience violence, and this is a problem that we have in Chicago, you're 5 times more likely to attempt suicide. If you use substance use or you have some exposure to substances, you're 3 times more likely to attempt suicide. Now, in Cook County, we can see that minority groups, or LGBTQ+, Now, a big jump, almost 40% seriously considered suicide, almost half considered suicide. There's also increase in female over male. And then if you look at ethnicity and racial background, we have about quarter multiracial, and then Black and Hispanic at the highest risk of that. Now, also we know that Black adolescents are most likely to use firearms, which increase their rate of completion. So, you know, if you're overdosed, you have a good chance of surviving that. But if you're going to use a firearm, you have a very small chance of surviving. Now, there's a few also association related to obesity. There's some trends in obesity in adolescent that seems to be associated with suicide. That's not true for adult. There's no association in adult. And there's also trends related for poverty level. That's an interesting study that's been done. So the more county that had population below the federal poverty level, the more likely you see suicide risk is going up. So, you know, we're gonna at some point need to talk about upstream effects. You know, we're basically talking about a crisis, how we deal with a patient, but what are causing these type of problems? Now, health disparity is a big problem, and we're not going to tackle it by increasing our mental health force or increasing services. We're going to have to tackle this in a different way, and that's, I think, where the policy and changes need to happen. I don't want to talk about suicide without mentioning what the new 988 number, the SAMHSA, a new number. That's something we want to spread, become the 911 number that, you know, I hope people will know it, know when to use it. And this real success is when our kids don't use it. But for now, we're going to really have to promote this number. To briefly talk about substance use, that's another problem that we're tackling. And why that's important to discuss in adolescents. Substance use is a developmental disorder. There are very few people who develop substance use starting age of 40. Most of the people who develop substance use develop it in adolescence. And that's very important to know. And also important to for policy, and we'll talk about that. But if you look at Illinois, we're not the worst, but we're not the best state when it comes to adolescent substance use. We're about 8.3. If you look at why that's important for us, well, if you start using substances early on, you're more likely, the earlier you start, the more likely that you're going to continue using your adolescence. So anything that we can do to delay the exposure and delay especially early adolescent is extremely crucial, like 10 to 14. That's a very sensitive time. That's we need to kind of deploy our intervention there. The most common use is, you know, cannabis, followed by alcohol, and then other type of uses. Now, what's happening in marijuana? I will not have time to show you that. The legalization of marijuana did not lead to increase in substance use in adolescent, at least based on Colorado data. I mean, that's too early to tell, but that's what we have for now. But what really led is change in perception of how dangerous marijuana is. The perceptions now that this is not dangerous, and it's not dangerous like you know, other substances, and probably not as bad as alcohol. But that's not true in adolescents. So we have many studies showing the chronic use of cannabis in adolescent substantially increase your risk of psychosis. I took care of kids who developed psychosis with no family history of schizophrenia. And some of these kids, despite the fact that they will stop, they continue to have psychotic symptoms. There's 10 studies showing that, but the perception of cannabis use in adolescents changed. They don't think it's a dangerous thing to do. So now we'll see the many states that legalize cannabis, we'll see if the rate will go up or not. That's too early to tell. But again, the more exposure you have at an early stage, the more likely that you're going to develop substance use. NIDA has a great tool for adolescents, videos by adolescents. it's worth mentioning. This is a summary of some of the findings from the survey, what's going, in the wrong direction, what's staying the same. Well, we did, the good news, so we did achieve some changes in terms of decreasing bullying in school. Well, that's not cyberbullying, or here they call it electronic bullying. So we still have work to do there. So, in 2020, the many organizations came together and really kind of ring the alarm for a crisis. So we are in a crisis mode in mental health now in adolescents. And if we don't make a change in the next 5 years, we'll be in a really worse place. Now, why that's important? Because this leads to all sorts of problems, not only suicide and substance use and homicide and trauma and violence. There are all sorts of things that we're going to be dealing with. Now, why is that up? That's probably a 1 hour discussion by itself, so we're probably going to spare you. But I think Dr. Gorman described many of these things in her introduction. They're also a part that I don't want to miss. I think the parents are not doing well. It's not just our kids not doing well. So the attunement of parents to teenage makes a huge difference in their mental health. And I can throw this slide to show you. This is a great study by Richard Weisberg at Harvard. And this is a survey asked the kids what they care about the most. Achievement, happiness, or caring for others. And most of them put achievement first, happiness, and caring for others is low, which tells you that we have another crisis, which is a moral crisis coming our way. Now, if you ask the kids what their parent thought of, they'll say, well, they probably rank the same thing: achievement, happiness, and caring for others. If you ask the parent, that's not the case. The parent said happiness and caring for others, and then achievement. So how's that message being translated and getting lost? That's a whole different story. But that's also an interesting point. I'm going to skip this slide and move on. But this is a great document if you're interested in learning more. This is from the National Academy of Science, and it's called The Promise of Adolescents. You can download it for free. It has a great review of some of the stuff that I showed you here. There's also another one that it's worth looking at, which is by UNICEF, and talking about all the opportunity of intervention. I did some work for UNICEF 15 years ago during the Iraq War, and mainly to try help establishing what we call safe spaces where kids who are fleeing war can come and feel safe, can talk about their experiences, can play, and kind of try to get back to a normal level. What I think we need to create is to create safe spaces for adolescents, not in clinics, not in a system like we have, but maybe Canada has like a youth center that they open for kids. They can drop by, can connect, meditate, learn, study. We need to do something different than the way we're doing, because what we're doing is not working. Obviously, you can see it on. I'm going to skip this for the sake of time, and we cannot talk about adolescent without talking about getting them involved in this. We need to ask them what they think about it, what they think about mental health, what they think about what's best for them. But you can see that there's still a role for parents, that they still get their information from parents. They think the school does play a major role and should play even a bigger role. They think that mental health should be taught in a curriculum in school, and there are many evidence that that's the only way to reduce stigma, which we didn't really get to talk about today, is to expose them to that early on so they learn about it and not really shy away from getting help. Now, with the last 2 minutes that I have, I want to talk about how can we envision a different system. Well, we don't really have a comprehensive mental health system. We have a crisis system. We wait for people to get in big trouble before we try to take care of them. And that's not the way to go about this problem. We're going to have to really change that. We're going to have to address the stigma by having more curriculum. We're gonna have to do prevention, targeting high-risk families by doing something like positive parenting program. We're gonna use digital format and collaborative care model like Dr. Laturpong programs here. We have to get mental health to be part of health. There's no health without mental health. That's the WHO mantra. We have to reduce historical disparity, change racism, also change the way if we're taking care of adolescents, but we see the parent not doing well, we should take care of the parent. Right now, we refer them out to get their own care. We should try to kind of keep a central, the person doing that work. And the last part, Vikram Patel, who's big in global mental health now at Harvard, won a 10 million star award from Texas to basically try a new program by training community worker to do prevention work and kind of do some intervention at a level way before the clinical work. And this is a 10 years program, so it'll be interesting to see where would that go. But we're gonna have to make a change. And I think the best part that I always talk about, this was the theme for the American Academy of Child and Adolescent Psychiatry for the last 2 years, is capture belonging. Help adolescents capture belonging. Belonging is a very important part for adolescents. They have to feel that they belong to a bigger cause, that they have to feel like their identity is part of a bigger identity, and they have a cause and a hope for the future. So I think we're gonna have to really get school involved to do more prevention and improve social connection for our adolescents. And I know we're almost out of time, but there are great resources out there if you want to learn about what's been done, but we have a way to go. But like I said, we are not doing well. But this is a great opportunity to change this from down trajectory to an up trajectory with these adolescents. This is a great time for intervention. So with that, I'll end here. Thank you.
Yeah, big question. So thank you very much. A lot of covered a lot of ground in a short period of time, which I really appreciate, and really considered all of the different pieces that play into youth and adolescent mental health. We'll open up for questions. Dr. Laturpong is watching the chat, so if you are watching via Zoom or joining us via Zoom, please type any questions into the chat. And we've got folks around the room ready to hand out mics, so go ahead and raise your hands. While you're getting hands up, I'm going to throw out one question, which is, you talked about a lot of the different things that play into adolescent mental health. It talks about impacting upstream factors. If you were a legislator, or if you were going to put forth legislation in the state of Illinois, what do you think should be the area of focus, or the top two things that we focus on as a state?
I think tackling violence and the absenteeism in school, because school should be the place where we probably deploy our intervention. It should be, if you look at the number of social worker in school that's been requested, we never met that. We never had enough people in school to develop any mental health intervention. We should really invest in that. We should invest in community intervention, getting faith leader, getting people on the ground to take mental health as a priority. But for us, I think, violence, poverty, creating economical opportunity, capturing that belonging for these adolescents to really change, so they're not feeling that belong to a gang, but rather a bigger cause, something that will change their life. I think that's where we need to go.
I'll take a question over here.
A tearjerker, but as someone who is a product of early intervention of mental health as an adolescent, I'm really glad you're doing the work that you're doing. And I'm also really shocked you mentioned kind of offhand that you guys have been talking about how mental health is not covered in curriculum in med schools and residencies. is there anything I can do that we can do to help that? That's wild.
Well, I just want to be clear, it's covered, like in medical school, we do have a required psychiatry rotation, but I was referring to pediatric.
Right.
You know, pediatrician, many elect to do a few weeks with us as an elective, but it's not a required rotation yet. I think it probably need to be. But remember, no matter what, we threw money at, you know, psychiatric problems in so many ways. I think we have to tackle this outside of the healthcare system. We have to go to school. We have to go to community. The current healthcare system is a crisis system. If you're so ill, so sick, then we'll try to take care of you, but there's not enough for people even to take care of you if you're that sick. But to change that, we're gonna have to also tackle, we have to stop people from getting that sick and capture them early on. You know, medicine did a great job with vaccine, so many, you know, preventative tools that I think the mental health world need to go there. Need to start investing in ways to prevent these problems from becoming so severe.
And that community health worker model that you were mentioning, which I work in hospice and palliative care, another connection that's also something that they're looking into, right, to change the conception. But the fact that people may go into practicing as a pediatrician without feeling equipped to like deal with it on the spot. And also you mentioned just bringing attention to like the fact that then people get put in like for a referral. And that it's like, it's not dealt with, and then it's like, could they get in with you, Chicago? Probably not, you know, like kind of continuing to help that family and patient advocate is really important.
Question from this.
Hi. So question from the chat from Caitlin Zone to Anita. Currently our pediatric patient units are experiencing an influx of psychiatric patients with limited bed and health facility. What adjustments can our medical facilities make to meet these demands?
Unfortunately, in Chicago, there are many beds that we lost during the pandemic. So we used to have a unit at Ingalls for adolescent that closed down. Rush closed down their unit. Lakeshore, which is the largest number of psychiatric beds, also closed down. So there were, you know, about I think close to 80 beds in Chicago that we lost in 2 years. And now, if you see where are these kids going, they're boarding in our pediatric floor, in our emergency rooms. And even if they make it to an inpatient unit, they're staying there for 3-4 days, which is not enough to really do any meaningful work. I mean, keep them safe, you know, if they are at an imminent risk of harming themselves. I think that the future for us is to invest in like day programs, like partial hospitalization programs, intensive outpatient program, where kids can go get their treatment, but go back and sleep at home. And that's growing. But it's mainly growing in the private sector. There are very few public investment in growing PHP in Chicago. There are very few programs. So that's here.
In the back. Also got one. Let's do the one over there, and then we'll go to the back next.
Hopefully my question's a quick one. So you talked a lot about adolescents. Obviously there's a whole age group before that, and you mentioned that in one of your slides. But are there links between issues that arise in the age group before that can be followed through into the adolescents, so that, you know, you mentioned like vaccination happens at a very early age. Are there interventions that could be at a much earlier age group that can help divert some of the issues that we're seeing in the adolescent age group?
That's a great question. I think, you know, if you ask people who are working in the stigma world, and stigma is one of them, there's probably a few big hurdles. Stigma is one of them, then lack of access is another one. But stigma is common because you see patients coming for us after being, you know, suffering for 7 years and trying to seek help because they've been pushed at the end to do it. And no matter what you look at in terms of anti-stigma program, all of them failed except one program, which was done in Canada in schools. And that's presenting the young kids, pre-adolescent, with mental health curriculum to learn about ways to keep themselves well, how to identify problem, how to go about seeking them, what's psychotherapy look like. And that's the only way to change. If you're gonna change stigma in adult, it's very tough job. And WHO had a great program called Open Doors, trying to tackle stigma and like for schizophrenia. It worked, but it's short-lived. Like as soon as the program ended, all the effect kind of lost. So, you know, that's where we probably need to go and teach kids about how to take care of them. Sleep, another big thing that I didn't have time to talk about in adolescent. Adolescent treats sleep as, we don't need it. We can sleep 4 hours and do well. But that's the golden age of sleep. That's when even research showed that starting school later had effect on mental health. And despite that research, very few school districts adopted that. But I don't know if I answered your question. I think that would be one of them. Also trying to, you know, get help, not from a mental health professional, but the role of family, friends, community, you know, finding these safe spaces for kids where they feel safe and can talk about these things and not worry about it. Getting peer support is very important for adolescents. We can find ways to do that at school, having some group intervention at school. That would be another way to do that.
That was a part of my question too. Sorry, strategy for intervention. Strategy.
It's strategies to increase adolescent resilience.
That are proven effective.
So, you know, resiliency in general is a really interesting topic in mental health because we try to measure that. You know, the true definition of that, if you're exposed to an adverse event, you're not just getting by and cope, that's coping. Resiliency is where you can actually overcome that, you know, adverse event and excel and do really well. But we know from looking at research all over the world that having a secure attachment figure, somebody who really believed in a teacher, an aunt, a therapist, but somebody who really believed in you and established that connection is what got most of people out of these adverse events. So telling teacher, you know how to be a good listener, how when somebody's struggling not returning homework, instead of telling them that you're disappointed in their performance, maybe try to figure out why that's happening. What's happening at home that they cannot do that? You know, trying to empower them. And that's easy to say and not easy to implement. But if you ask most people, they say one important figure in their life got them through what they got through. And trying to find that person is really what I'll say is the best way to promote resiliency.
Thank you very much.
Thank you. Appreciate it.
What a wonderful way to get us started.
And a lot of really critical questions being asked here, which I appreciate. You aren't making it easy for a speaker, which is good. It's important for us to be thinking, you know, beyond the traditional things that work. So next,